G'day everyone, my name is Joshua Barton. This is the third video for PAR5430, the drug facilitated intubation procedure. So, we're going to cover a few topics. So, intubation plans, that includes our crew briefing, how to perform direct laryngoscopy. We're also going to do ETT placement, how to confirm when we've got a tube in place, and also the post-procedure cares. So, let's get into it. Okay, so I've got my optimal patient condition that we would have discussed in the previous video. So, we've got our prehydration, our pre-oxygenation, we've got our nasal prongs on, our adequate positioning, so sniffing position, head elevation, and also some ramping if required. IV access, we're going to manage our patient's condition prior to the drug facilitated intubation and have all our gear and equipment set out. So optimal patient position is this one described here in the photo. And this is from the previous video. So as you can see, I've got all my equipment ready. I've got all my baby valve mask and my laryngoscopes, and I've got all my primary airway stuff, and then also my emergency airway fallbacks, and then I've also got my drugs down in the corner there. So this is how I'd have my scene set up, and this is at a different angle. So my team allocations, I'm assuming I've got a 4-person crew, 2 Bravos and 2 ICPs. So the lead role will be undertaken by myself, so that's running the entire job, directing and delegating, and also performing the skills of intubation. So my airway assistant, which will be to my right, will be an ICP, or a trusted Bravo if there isn't one. My drugs and vital signs assistant will be wherever the IV access is in place, able to see all the equipment, because I'll be looking at our vital signs as well. I'll have a runner and an overall assistant. My airway assistant being my ICP, I'll brief them on the role. I'm sure they'll be aware of how to do it, but I'll also explain how I like to do it. So, as listed here, pass intubation equipment to my right hand when requested. So it'll be bougie, tube. Once I've secured the ETT, then I'll get them to remove the bougie, grab the tube, tie and assist with. So at any point, if I need any assistance with cricoid pressure, or they'll be able to aid in that, and also they'll be able to fall back to the difficult airway algorithm if required, and then assistance with confirming a tube. So my drugs and vital signs assistant, basically their role is going to be administer certain medications in a certain order. I will outlay which drugs I need to be given, how many micrograms or milligrams, and how many mils, and in what order to push them, and after each drug to confirm back to me that this has been given. So I'll alert them of a few vital signs that I need to be aware of, but obviously if anything comes out of normal parameters, they should notify me immediately. So the runner, their overall assistant, so I'll assist with vital signs, extrication equipment, liaison with other resources on scene, communicate with communications, and gather extra equipment as required. So they're basically just an all-round runner and can jump in with any task as required. Prior to any intubation, you should have an RSI checklist, and you should go through that checklist. So first of all, reminding yourself of the indications, because it's quite a heated scene, so we need to make sure that we meet our indications prior to the procedure. So obviously, pre-oxygenation assessment, access, suction, equipment, position, drugs, and also brief the team prior to RSI. Really important to do all these. So for the drug facilitated intubation, we need to push our drugs. So I've chosen from my induction agents of fentanyl, midazolam, and then my induction paralytic of rocuronium. So 100 micrograms of fentanyl IV, so that's 10 mils, and I'll also be using 8 milligrams of midazolam, so that's 8 mils. And I'll also be using 96 milligrams of rocuronium, which is 9.6 mils. So I've mixed that in 100 milligrams and 10 mils. The reason I've done this is I'm assuming he's an 80 kilo male. So I'll get my drug assistant to push those, fentanyl first, then midazolam, and then rocuronium. And so once that happens, we'll wait for our patient to respond. Okay, so it's been 60 to 90 seconds since we pushed our rocuronium, so we're happy that that's taken effect. I can feel that it's taken effect. So you happy to proceed with the intubation, Chrissy?
Yeah.
Okay. A quick overview of direct laryngoscopy before we get into the skill. The indications is visualization of the glottis, and the purpose of removal of foreign body, but in our instance is going to be an ET insertion. So quickly looking at our blades here, so we've got Miller Macintosh, so I'll be using a Macintosh size 4. So some of the anatomical landmarks we're trying to achieve. So when we place the blade into the mouth of the left hand, as you can see, we're displacing the tongue by lifted upwards of 45 degrees. And what we're trying to do is get it into the molecular groove, which is noted here. And we're going to lift all that up so we can see the chords, which is just noted down there. So as we're placing the blade into the tip of the mouth to start off with, you'll hear me call out that I can see the uvula, the back of the mouth, and also the tonsils. Now this is a good indicator to see my anatomical landmarks as I'm proceeding in. In some circumstances in a difficult airway, I might not be able to visualize all these landmarks. So this could prompt me to think of quick strategies to try and rectify this. So here's just a cross view of the airway, so you can see from a different angle how big the tongue is before it's been depressed, also where the molecular groove is in the glottis. So without any actual manipulation, it's quite difficult to pass or see anything through that. So I call out a grade 1 view in this video. So what that basically is just a grading system. And so it just grades on how much of the glottic aperture you actually see. So as you can see here, grade 1 view, you can see everything, and it's the easiest to pass through the tube.
Yeah.
Okay, cool. So one more ventilation. Alright, so we're aware that when the saturations get below 90% to alarm me. Okay, so OP out, OP to my right, bit of head tilt. When I place the laryngoscope, obviously I'm placing it to the mouth, so I've got a decent mouth opening. I can use the technique called, this is a technique if needed, shown here. Okay, so I'm looking down the mouth, I've got a view of the uvula, I'm also looking for the tonsils. I've swept everything to the left and I've placed it to the vertical groove. I have a grade 1 view of the chords. Can I please have the bougie with my right hand bevel tipped down? Okay, so bougie is through the chords. Alright, can I please have the tube over the bougie, please? Holding that in place, merging out for the teeth. And if I was to find this was difficult, I could always do some laryngeal manipulation. I have the tube, hold the bougie, tube through the chords, and that's 22 at the lips. Okay, remove the bougie for me, please, but be careful of the flick. So if I was to find that difficult, I can always provide laryngeal manipulation. So I would do that with my non-dominant hand, or also my right hand. And how I do that would push down. I could use backwards, upwards, rightwards pressure, or just manipulate until I could see the chords. And then from that, I would pass it over to my colleague to place the hands over my hands, so that way I can continue with the intubation. Alright, so now that we've got our tube in place, we're looking for to make sure we've got it in the right spot. So to do that, we look for our end tidal waveform. So to make sure we've got an adequate waveform, we have more than 6, we've got adequate tidal reading, and it's comparative to the bag. With that, we want to feel resistance and the feeling of the bag to make sure to see what it's doing. So you want to have nice compliance of the bag with minimal resistance, if none. So looking at the rise and fall of the chest, I want equal rise and fall of the chest, and I'm also going to be listening for chest sounds. So that's bilaterally, and to make sure that I've got sound everywhere. So if I only heard it on one side in particular, predominantly the right, I might have a right main bronchus intubation, and that would have to be pulled out a little bit. Other ways you can tell if you've got intubation in place is obviously x-ray, but we don't really have that in ambulances. And obviously an improvement of the patient's condition, so we want to see if our saturations come up. So we're going to place the tube tie in, so if Chrissy wants to place the tube tie in, please. So I'm going to hold on to the bougie up, the tube up high.
Do this.
There we go. So this is obviously something you need to think about post-intubation, is how we're going to secure the tube. So lucky with the Thomas tie here, it's got a bite block in it, so we don't have to worry about putting an OP or anything in there. So we've had a first pass assess, first attempt. So our post-intubation cares revolve around a few things. So maintenance sedation, first of all, the indications is inadequate sedation in the paralysed patient. So think about with the signs of this, you're going to have increase in heart rate and blood pressure together, diaphoresis and lacrimation. So if the dosages and drugs we're going to use is fentanyl, 300 micrograms, and midazolam, 30 milligrams in infusion, 1 to 10 mils per hour, until you get your desired effect of sedation. So maintenance paralysis isn't always required, but if it is needed, the indication is traumatic brain injury or non-traumatic brain injury. Sedation alone is not effective in being able to ventilate and oxygenate, so basically they're fighting against you with coughing, gagging, movement, biting of the tube. So if we do go with paralysis, we're going to use rocuronium, 50 milligrams IV, repeated at 15 minutes as required. So supportive medications, you can use metaraminol for post-intubation hypertension. You can use sodium chloride 0.9%, 250 mils, and then reassess. We'll be targeting blood pressures of 120 to 140 systolic in the non-traumatic brain injury. We can use atropine for bradycardia, and we can also use adrenaline for bradycardia and poor perfusion. So a ventilation strategy, you can either do this with a backbone mask or with a ventilator, but what we're going to try for is a tidal volume of 67 mils per kilo of ideal body weight. Have PEEP set to 5 to 10 centimeters of H2O. We're going to try and get end tidals around 30 to 35. Breast rate varies a bit here from 10 to 20 breaths per minute, so start somewhere about 12 and then work your way with your parameters if you need more ventilations and increase it or decrease it as required. So things to think about, bag valve mask is relatively straightforward and simple. You connect it, you squeeze it, but you're going to have difficulty in trying to get the exact tidal volume, and also your respirator can be quite difficult as well. And you lose a clinician, and it can be quite dangerous in the back of a moving car. So if you have a ventilator in your service, lucky. So if you're going to use one of them, obviously there's a lot of different settings that are available on these things. So titrate it to your patient and also as your service requires. We don't have them in Queensland, so I don't know a great deal about them. So your ongoing management, reassess your patient, manage your vital signs, keep them warm, they can lose their body temperature quite quickly, make sure that tube is cured, keep your patient position adequate and keep reassessing that. Oxygen status, make sure you've got enough O2 for the transit, put a gastric tube in if you can do those, plan your extrication, keep that tube safe, make sure your patient's safe and keep your monitoring together. Really also important, make sure you check your ETT cuff pressures through a mammometer. You don't want to overinflate that cuff. Here's my references. Thank you very much. Hope you enjoyed it.